later. This is Meredith Rodriguez. I'm with the EIC. I'm a project manager with the EIC. Today we have two of our fantastic EMSC program managers, Karen Moore from South Carolina and Kathryn Shaffer from New Mexico, who are going to talk a little bit about their medical recognition programs, how they got started, what were some of the obstacles, and how they leveraged some other state priorities. So just a quick reminder to please mute your phone or your computer when you are not speaking. That way I can leave all lines to be open and interactive, and we can hopefully have a good discussion and some good conversation following each of their presentations. So I'll begin with our acknowledgements and our disclaimer. The IC is supported in part by HRSA of the U.S. Department of Health and Human Services under the following grant number. This information or content and conclusions are those of the author and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. So a quick agenda for the day. As I mentioned briefly, I'll begin with just kind of an overview of this performance measure and where we are today as far as how many states have recognition programs and what are the different phases of establishing a medical recognition program. And then we will turn to Karen Moore from South Carolina, who will talk a little bit about getting started in the first phases and what is the role of the state partnership manager in getting a recognition program started. And we will follow that up with Kathryn Shaffer from New Mexico, who did a lot of work overcoming obstacles and getting really to recognition of her first hospital. So thank you both for they put some awesome slides together, and it's going to be a really great presentation today. Are there any questions at first before we get started? Okay. So I will just kind of review the goal here, and that is that it's EMSC performance measure number 4, and it states that by 2020, 25% of hospitals are recognized as part of a statewide, territorial, or regional standardized program that are able to stabilize and or manage pediatric medical emergencies. As I'm sure you all are very well aware of this performance measure. Brief overview of the existing pediatric medical recognition programs. We have 15 states that have official recognition programs, and you can see them listed here: Alaska, Arizona, California, Connecticut, Delaware, Illinois, Kentucky, Montana, New Jersey, New Mexico, Ohio, South Carolina, Tennessee, Utah, and West Virginia. So recognition criteria is based on the 2018 Pediatric Readiness and Emergency.
Hello? Meredith, I think you dropped.
Hey, Meredith, I think, oh, she sees it, T. She's coming back on.
Okay, thank you.
Sorry, folks, give us just a few minutes as we jump back on. Thanks, everyone who continues to join, and feel free to add to the text box. This is Kate Remick. So I'll just continue where Meredith left off on, oh, is that Meredith?
I'm back. Yes, thank you,
good.
Kate.
Okay.
I'm sorry, I don't know what happened. The call dropped there. Sorry, I was talking, but.
No worries. I was just about to tell them about the stages of recognition. Go ahead and, oh, okay. So just as a reminder of what the stages of recognition are and kind of how we develop that process. So stage 0 is really, just getting started, not really having a team together yet, and just beginning to, jump into the process. Phase 1 is really beginning to develop your core team, who you're going to be able to work with. And, as states begin to work on the medical recognition, it's really important that those are individuals that you can work closely with to really establish next steps and identify what the most critical points will be as you move forward. Phase 2, just as a reminder, is where you begin to really understand the framework in your state of how you might work through this process. So different states might have, trauma systems that are really well developed and structured and have served as a guide for kind of leading recognition programs. Other states may have less developed trauma systems and really want to work primarily with the health services to develop a separate track. Other states have identified other mechanisms where professional organizations have been heavily involved, and so that's really phase 2. Phase 3 is really bringing in additional stakeholder groups. So that might be state hospital associations, state chapters of professional organizations like AAP, ASAP, ENA, NSMCL, and the like that can really help to support. And it's really the first effort in phase 3 is getting stakeholder support for the concept of pediatric medical recognition, and then really getting their support and approval of criteria and processes for recognition. Phase 4 is really developing a piloting process and or implementation plan, which would include, application and survey process if that's involved. And then of course, stage 5 is really getting to that first phase of recognition. So I'll turn it back to you, Meredith, to talk about the number of states in each of those phases.
Thank you. So that was, I'll just go back to this slide before. And this graph is a bar graph that shows the number of states that we have in each of those phases. And so there's quite a bit, 28, maybe nearly half of our states done in phases 0 and 1. And then the 15 that I had mentioned before in phase 5. And so that's kind of the overview of what the phases are. I was going to open a poll real quick, and we'll let it run for the next 10 minutes to kind of give Karen and Kathryn an idea of who the representation on the call. And so I'm going to open this poll, and it's really just what phase are you in? And if you want to just go ahead and put your answers in as we continue to talk, that would be wonderful. So here are the 5 phases, kind of giving you an overview of the stages of development of a program. And so we're going to next turn it over to Karen to speak about really getting started.
Hey everyone, thank you guys so much for letting me talk to you guys today about our Pediatric Recognition Program. I think I'm going to talk to you a little bit about getting our stakeholders engaged and kind of just how we got started. Meredith, you can go to the next slide. Just a little bit of background about South Carolina. This is our cute little state here. We got an estimated population just a little over 5 million, 63 acute care hospitals with EDs, and 15 trauma centers and 4 pediatric trauma centers. I did designate the children's hospitals on this map. You can see with the stars where they're located in the state. So you see there's a huge portion on the left side of our state that borders Georgia that doesn't have a children's hospital close to them at all. I'm going to go to the next one. This should look familiar to everybody. This is our Pediatric Readiness Project scores. A little bit of background about this. I was not in my position when the survey was sent out initially in 2013. That was my predecessor, but he did an awesome job and got a 100% response rate, which was fantastic. But I was here for whenever we did get the results, and these are the results that we had. So you can see that our national median is below, our state median is below the national median here. So we knew that there was some work that we needed to do. So the road to recognition, our first initial meeting, I called it that, but I really shouldn't have. I should call it the meeting that actually worked, because we had several in between 2014 and 2016 to get stakeholders involved, and we did not have much success. So I guess the first successful stakeholders meeting was in August of 2016. We actually got some folks to attend who were excited about it and who still help out with it to this day. And then probably the best thing that could have happened to us, we joined the Facility Recognition Collaborative at the end of 2016, and we were able to join in with some other states who were facing the same problems that we were and who were in the same boat that we were and just trying to get the same outcomes. So as part of that recognition, we were given a coach to work with who had a recognition, as part of the collaborative, we were given a coach who had a recognition system in place. and work with them and help us as we tackled this goal. And we were fortunate enough to have Rhonda Philippi, and her picture will be on the next slide, but she told us, well, why don't you have a retreat? Why don't you bring all these people in? So that's what we did. So we planned a retreat for January 2017, and we invited all the hospital ED managers. Sent out a letter. It came from my office on our letterhead, and we invited them to a full-day meeting out of my office. I work in the State Department of Health, so nobody wants to come here, and they definitely don't want us to come see them. So we kind of held it at a neutral location, and had a full day of meetings scheduled. And we also reached out to all of the EMS for Children stakeholders and got them to come because we wanted as much involvement as possible. You can go to the next one. So this is what it looked like. There's Rhonda. She's fantastic. If you haven't met her, you really should. She's just the best. She was a perfect fit for us, and as far as the collaborative went. These are the people who attended and the memberships that they belong to. Pretty standard people, but we did get a good response. I forgot how many were there, but it was in the 30s, which is a huge improvement from the 5 that we had previously. I did bold the last bullet point, DHEC legal staff. DHEC is the Department of Health, which I work for. We invited them along and included them in our meetings because we wanted to make sure that we were doing everything from a state standpoint that we were supposed to. Not calling it like a designation, calling it a recognition, and making sure that we were following all the rules as far as the state office goes. We involved them on the front end so that way we wouldn't have put in a lot of work and then had been told, no, you can't do that by our state legal staff. So they're good people to have, whether hospital or state. And you can go to the next one. So passionate pediatric advocates. These are my people. These are the people who showed up. These are the people who still show up to this day. So basically that group of 30 from the stakeholders retreat kind of went down to 15. And they were actually people who were really vested in pediatrics, people who took an interest in what was going on and what we were doing. They were committed to better health care outcomes, and they were willing to show up. They were willing to put the work in. So this was our group. These were the people that I knew I was going to be working with during the project. So what we accomplished a lot. We implemented some criteria for a basic level program. So ours is completely voluntary because that's what our legal staff told us to do. And we are in the process of finalizing our advanced and comprehensive. As we speak, we've got a meeting next week. We also created a toolkit for facilities to use, frequently asked questions and things to make it a little easier for them if they were interested in applying. We defined who we wanted to be the site review members. There's an application process for that, and they have to send in additional information. We also created mentorship opportunities. So we never wanted a facility to contact us and then we say, well, no, we're not coming, or no, you don't meet these things. We wanted it to be very, very open and say, well, how can we help you get these things so that you can become recognized? What's the next? So this is a little bit about what we accomplished. So here is our application that we created. It's got a lot of words, went through that DHEC legal staff. So, but this is the final document that we came up with. We put in a lot of work for this one, and it requires a lot of signatures, I know, but they wanted to make sure that we had everybody on board before we started recognizing. Next. And then this is actually a tool that we created for our site review visits. So this is something that our site review team uses when we go out on visits. It lists all of the criteria, whether it was expected or desired and whether they met it or not. And it's color-coded. It's very fancy, and I didn't create it. I can't take the credit for it, but it's really cool. And if you go to the next slide, at the end, it prints out like what we call a pathway to success. And it basically just says, everything that they met, what they might need to work on, and our notes and comments. And we present this to the facility at their visit or after their visit is over. These are my people again. These are the great people who have been recognized so far. We've only got 3, but it's better than none. So we've got a couple more visits scheduled for the coming months, so we're pretty excited about that. But I always take a picture of them with their certificate, and there's me in the last picture, and post them on, our website or social media as much as we can, just to get the word out there and how proud we are to have them as part of our group. So I told Meredith I'd talk a little bit about my role as the EMS program manager. I put consistently meeting as the biggest bullet point here. We have a rule in my office that we don't cancel meetings, we reschedule. So unless there's a hurricane, which happens a lot, we have to cancel them then. But we always reschedule them for after everything's done. But we consistently met. There was all these communication, everything that was going on. These meetings were monthly sessions to get the program up and running, and they were all-day work sessions. One of the physicians who works with us told us that it was easier for him to get an all-day meeting in than to do several couple-hour meetings throughout a couple of months. So we decided to do all-day meetings, and it worked out well because then we were able to have coffee and lunch dates and, chat and get to know each other on a personal level. The no judgment zone, we had several hospitals participate who were competing hospitals. So they would say, so whatever was said in those meetings was kept confidential. We didn't judge facilities for things that they suggested or things that they did in their hospital that weren't included in the criteria. So we just made sure that everybody knew up front that this was really a group effort. And present at conferences. People keep asking me to present. I'm not very good at it, but but they keep asking me. So so I've done that at several conferences, at our Rural Health Conference, our EMS Conference, our Trauma Conference. So we're trying just to continue to market the program and let people know why they should be involved. And the next one. So another one of my key goals was keeping the team engaged. Not only did we have these wonderful breakfast and lunch meetings, we really did get to know each other. We kept emphasizing the why. Why are you here? Why are we doing this? Oh, hello. I also gave our task members some objectives and goals. I didn't just bring them in for a meeting and say, hey, let's talk about pediatric readiness. What do you want to do about it? So they actually had things that we were working towards at each meeting. I involved them in the agenda planning. What are we missing? What do we need to do? I held them accountable. That's a big one. If one said that they were going to do some research on this or write this, then I always kept in touch with them and made sure that they had it ready for the next meeting. And then I just wrote our mission and vision here. The mission is pretty standard, so we knew we could meet that because we were going to recognize them as pediatric ready, but I really like our vision, ensure that every child in South Carolina gets the best care in every emergency department every time. Because I'm asking them to talk the talk about pediatric readiness, I got a couple of quotes from some of our stakeholders about why they participate, and I listed those here, and this is one of our huge supporters. She is the Pediatric Trauma Program Manager at Prisma Health, which is a local children's hospital here in Columbia where I live, and her son races four-wheelers and plays lacrosse, and she wants to be sure that any ED he may have to go to is equipped to treat children. So she wanted to make sure that all of the hospitals get involved within our state. And the next one. This is another huge advocate for us. She has a lot to say. I won't read all this to you. I'll let you guys will read it. But Candi is also works at Greenstream Medical Center, which is in Myrtle Beach. She's been a huge help as far as this goes. She's helped to present. She's helped sit at the booth at a little conference and give out information and talk to people about why they should be ED or PEDS ready. So she has been a huge advocate for the program, and I just couldn't ask for anything better. And she just says it better than I could ever say it in this slide. And I like the sentence, by keeping the little patients our focus. We've been able to develop comprehensive deliverables, collaborate well, learn from each other, and ultimately make a difference. Yeah. Next slide. So as we move forward, we've changed our meeting format to bi-monthly. Now that we've got something in place, we don't have as much to talk about, but we still want to meet. We still want to keep the momentum going, the excitement, the enthusiasm. Marketing for the program, we've only got 3, so we're really trying to get more hospitals involved, and that's what we've been doing lately as far as presenting at conferences and talking to people, as many people as we can. We're doing continuous QI and PI. We're looking at what's working, what's not working, how can we make it better, and moving forward, especially the next 2 levels that we're implementing. And we're remembering the vision. We're remembering that this is what we set out to do, and this is and look at what we've already done and where we've come from. And this is one of my favorite quotes, and I include this in some of my presentations. We're all in this together. They are all our kids. So that's about that's a huge statement to say, especially when you're trying to get more stakeholders involved. And that is it, all that I had for you guys. This is my email address and my cell phone number, and that really long address is is our website. If you need it, I can email it to you. But that's got all of the toolkit information, everything that we have about Peds Ready on there. You're welcome to come ask me any questions you may have. So that's it for me.
Thank you, Karen. That was wonderful. Great, lots of great information. Any questions?
This is Diana. Quick comment. Karen, I've sort of been monitoring your progress over the years as you've embarked on this. I think the piece that impressed me the most with the work that you've done thus far is that I'm not sure if you can address it or not, but how quickly you got your group together, how quickly you got them to buy in, and how quickly you were able to achieve success in getting the first hospitals recognized in your state. And I know the marketing goes on as well, but, and I guess the second question I would have could you briefly address your review process when you go out to the hospitals? How do you do that? Who goes with you, and do you need to recruit, and are you recruiting on a regular basis?
Yes. To answer your first question, I was just extremely fortunate to have a group as interested in it as they were, and I kept bugging them. Well, not bugging, that's not a good word, but I kept, contacting them about the importance of this and showing them the data and showing them the national guidelines about, and that we needed to do this in South Carolina, and that's how we got it implemented so quickly, in my opinion. We had a really great group to begin with. They still meet. They're still the ones that are coming to the table and bringing the information. And as we move forward, I'm sure they're going to continue. I hope so anyway. For our site review visits, we decided it has to be a physician with pediatric experience and a nurse with pediatric experience and me. So those are the 3 site review members, and what we do is we schedule a time that works for the hospital, and we go out, we get a tour of the children's hospital, the ED. We look at the equipment list that we created, and we check off what they have and what they don't have. We look at their policies and procedures, and we fill out basically that Excel sheet that I showed you guys. And go through and make sure that they meet all of the criteria and what they're not meeting, what their strengths and weaknesses are. But it's only about a half-a-day visit, and we always try to leave them with something positive. Or the 3 that we've done have been very positive, and we haven't had to do a lot of expectations or recommendations, if that makes sense.
It does. Thank you, and congratulations on your success.
Thank you.
You've worked hard, and your folks, your team is obviously very committed, and you do a nice job keeping them engaged, which I think was something that you stressed early on. Thanks.
Thank you.
This is Melissa in Idaho. I just have a question. Do you pay that physician and nurse surveyor, or are they part of the advisory committee, or how do you work that out for the site survey?
Well, we don't pay them, but I do pay for their travel if they have to travel. So their meals and mileage and hotel room, but they do the actual visit for free. And they're usually part of our EMS for Children committee anyway, and so they're used to traveling for the program.
Any other questions, comments? Okay, well, with that, we will move on to Kathryn Shaffer from New Mexico, one of our most recent additions in recognizing their first hospital. So, Kathryn, if you want to take it away.
Hello, this is Kathryn. How's everybody doing today?
Hello.
Just wanted to make sure I took my phone off mute. Sorry about that.
I can hear you.
So in New Mexico, we've been working on a recognition system for a while. And I would like to thank all of you guys for this opportunity to work with EMS for children and do all sorts of fun stuff with kids. But also to recognize Dr. Sapien as being an amazing PI who's allowed us to work both on regionalization of care and state partnership together, where we have developed dovetailing objectives so that we can create some sustainability for the SPROC initiatives as the funding does come to an end in May. So we've been moving diligently forward on this so that we can make sure that we have something in place for 2020. So next slide, please. So in preparing you to understand New Mexico's recognition process, there's a little bit of background information about our state. We're the 36th largest state by population, have a total area of 121 some odd square miles, where we are the 5th state, largest state geographically and the 6th least densely populated state. So what that means is there's only about 17 people in New Mexico per square mile. So much of our state is considered either rural or frontier. And so preparing for daily tasks can be interesting and challenging to say the least. So the model we created for our Child Ready program was prepare for the ordinary to be ready for the extraordinary. Just in case, because those ordinary run-of-the-mill calls or patients, if you're ready to help them, then you could be ready for an emergency that could happen at any time. Our initiatives, by the way, are mostly community-based. So that was our idea at the beginning of that funding, was to make sure that we're preparing the community. Next slide, please. On this slide, the only thing that I wanted to bring to your attention is that we still have some longtime partners here. So back in 2012, when we received our initial SPROC grant, we started out working with our Center for Telehealth and the Center for Native American Health on creating rural and tribal programs that would look at closing the gap in distance and medical care that our pediatric patients received. And along came a really strong partnership with our EMS state office in Santa Fe through the Department of Health. So I just wanted to recognize them as well. We are fortunate right now in our political climate that we have Governor Michelle Lujan Grisham, who is truly one of our best advocates for children. So we believe the climate is right for New Mexico Child Ready, and we're preparing to make 2020 a great year for kids. Next slide. So in the beginning, there was this regionalization program, and many of you are familiar with this paragraph about organizing resources and patient needs, making sure that everybody is making effective use of all their resources. And Dr. Sapien really took that to heart, that we would have the right care at the right place and the right time for our kids. So that's where we even started the name of being Child Ready. So on the next slide here, our mission statement and goals. We always want to reduce morbidity and mortality, but really, again, it's about prevention. And we wanted to make sure that the key points in our mission and goals are preparation and self-determination for our communities, facilities, providers. So that we knew we couldn't make anyone do anything we created, so we wanted to do something that they could do for themselves. So again, the key points for that are preparation and self-determination in our Child Ready program. Next slide. With that in mind, we wanted to make sure that we were including cultural humility. New Mexico is an extremely diverse and rich in many cultures, so our efforts have involved creating culturally appropriate community engagement efforts, and we continue to strive to achieve culturally effective pediatric health care that will lead to the improved health of the community. This is the practice of being child ready. Next slide. Some of our motivating factors to really make this happen were participating in the HRSA collaborations, the facility recognition initiatives, and the PEC learning collaborative. And that really helped us create some great momentum. With those collaboratives, we had to get some of our state entities involved, and that was our EMS Bureau, the Trauma System, our regional trauma advisory councils, and our EMS training institutes. But additionally, because some of our resources and some of our hospitals are right along our borders, I needed to recognize some of the work that was already going on in Arizona and Texas, so that I didn't conflict with any of their recognition processes, and I could actually complement them with what we were doing here. So recently we had an AAP collaboration where we did some Navajo Nation site visits, and that was really insightful, and it really did actually create some more momentum in our Navajo Nation IHS and Albuquerque area IHS facilities to create proxy documents as part of our process. So, those are some of the things that are pushing us forward. The next slide is about a little bit of a reflection about our community visits, because where do our emergencies happen? They happen in our communities, in our homes, in our schools, at the healthcare facility that is a walk-in clinic. So we wanted to try and make our child-ready process encompass that community. A wonderful approach to engaging some of the major players in this recognition process is through our facilitated discussions that we've had along the way. And we bring a variety of community members together. And those members, their attendance was important because we felt with them there we could create an entire system that was child ready. The community visits aren't completely necessary for our recognition program, but it does help us solidify participation and commitment to the process. Slide. Successful community engagement efforts allow us to understand the communities better. It helps us to glean insight into their structure and how the community functions. It gives us the opportunity to get to know us and our program, which builds trust, because coming from a university, trust is often difficult because, sometimes other programs haven't always had great follow through. So there's some mistrust with that in our rural and tribal areas. The process itself of our community engagement and that facilitated discussion results in guidelines and outcomes and action plans that everyone has developed and approved, and then it really opens up some communication between team members and community members, very honest communications. And sometimes it even opens up things between community members that they didn't know, like that picture that we had. There was one person who was saying, hey, we could really use this, and then another person from across the room said, yeah, we offer that, let's work together. So it's very important in those aspects. The meetings are the opportunity to share knowledge, information, and resources. Next slide. The areas that we've identified through our community visits and through our discussions at various presentations across the state is that we really needed to focus the locations on locations and regions. So it's kind of talking about hospitals and EMS, about catchment areas and where they transfer to. So understanding the geographics of that of the communities. Implementing telehealth was crucial. Focusing on injury prevention for our communities was very important to them, and then having resources, either having them available from us or creating them within that community. Some of the things that we considered for a child-ready model were, like I previously mentioned, the overlapping communities and catchment areas, and including schools, EMS, and the various types of healthcare providers you would see in those communities, and understanding that we may cross state borders. One of our biggest telehealth users rarely sends patients down to UNM, which is the only level 1 trauma system here in New Mexico, because they go across to Texas, which is a quick little 30-minute helicopter ride or an hour and 20 minutes by car for that family. But ultimately, what we want to do is decrease unnecessary transfers through our programs. The next slide, oh, this is just a little map. I was trying to come up with a creative way to kind of show that we've been actually working on this for a very long time, and it just didn't seem like we could gain momentum with the barriers that were kind of in front of us from different things like funding or state laws or the political climate and changes in leadership. So this just really goes on to show you where we started our Child Ready implementation back in 2012. And then we created our regional model, and then we started with the Facility Recognition Collaborative. And it's really just been a journey for us. All of this has been a journey leading to 2019, where we're finally able to recognize our first hospital in Raton, New Mexico, Miners Colfax Hospital. Next slide. So we needed a process. We needed to be able to describe to our end users what a process was to participate in Child Ready. So we do have some guidelines, although this one is specifically, looks like we're talking about, could be referring to a facility. This is in general. So we need Child Ready to have requirements with leadership. We want them to be intent, to give us a letter of intent, or to let us know that they're in. And then we need them to complete an application, because we were using some verbal agreements in the beginning, and it really didn't have that sustainability if leadership changed or if people changed positions. So we needed something that was really a little more binding. We needed to designate a pediatric champion. And again, there was that letter of intention. We needed to make sure that people in the region knew about their recognition status, because we realized that although we were working with them and we gave them certificates, that if we didn't make it more aware to the surrounding communities, that it didn't have as much validation for that community. So on the next one is where we started. So really, we wanted to start with somebody who would allow us into their home, into their community, where we needed a foot in the door, because we really, if we don't have that person to vouch for us, then we're not going to get very far with that community or facility. So it was identifying our champions. And so that champion was anybody who could help us get the foot in the door. They could work in a hospital, EMS service, or just live in that community and advocate for the kids' health and well-being. So the pediatric criteria, pediatric champion criteria that we came up with is that individual interested and dedicated, has agreed to be a pediatric emergency care coordinator, which we've allowed some fluid definitions for what they need to do, and that would be to engage community efforts to prepare like community event, a bike rodeo, a CPR class, so that they're interacting with all different community members. And of note, you can have more than one champion. So if I engage in Silver City, I can have a champion at the hospital, I can have a champion at EMS, I can have a champion that is working with one of the injury prevention coalitions. So this is, the next slide is a demonstration of something that we created. We thought if we're going to be promoting this, we want to make sure that people understand. So we have these stickers that we created that will identify you either as
at the tone. Please record your message. When you have, or press 1 for more options.
I don't know if I should leave my name and number. That's okay. Somebody's going to get a funny little message. So this is just one of the ways that we can do it. We have our facility prepared. We have the EMS recognition. And in fact, in talking with our providers, they would actually like shirts. They would love to have something that says that they are Child Ready champion. So we're going to try and work on getting those for 20. Next Part of the facility recognition that we're working on in New Mexico is that it's not just pediatric readiness and ED, but that it does involve the community. So you guys are going to get tired of hearing me, but if we don't make the community ready, it's not going to work in New Mexico. Everybody has to be ready. So we want to start the pediatric readiness and the ED and then expand it out into the community if that's the way we have to go. We let all EDs know whether they are trauma or they're small and they're not 24/7, because we have some EDs that close at 6 p.m. that they can participate in the recognition. And there's no requirements for them to have pediatric specialists or inpatient care, but we've actually created a set of child-ready checklist or resource inventory for those facilities as well that they can use in addition to any other scoring tools that we have for them. On the next slide, we want to talk about these different levels. So we did decide that we would have a voluntary system that would have 3 levels. And if it looks familiar to some of you, it's because I borrowed from Connecticut and Kansas on their levels, and I just went with it. Thank you guys for sharing. I just love our community of sharing that we have here. And so our facility recognition, it can be based with hospitals, with emergency, but like I said, not all of our community health care facilities have EDs, so we needed to be flexible. And then our facility recognition was started first, but we actually took these levels from our EMS services. So we wanted to mirror that so that when you saw child ready, pediatric engaged, you were looking at it could be for EMS or hospital, and it was going to be called the same thing. So the criteria for that is on this slide. What we did do, again, there were some parts of it that we looked at their scores and we could improve on scores, but again, this is a self-determination thing. So while that's only part of it, as our Child Ready advisory, we had committee members and we had community members who participated in the development of some essential building blocks. So that's on a future slide. But they are able to pick from those things to build on their engagement, and so they can make their status higher. So everybody who has a PEDS champion and an assessment score can be our bronze level. And then as you pull from areas from these different building blocks, you can increase your level to silver or gold. So this is just an example of what our application looks like. Again, it was really important to have this process in place, and I didn't understand that until probably about 2018, because with changes in leadership and people changing in roles within the agency, if I didn't have something where I could go back and say, yes, you are participating on this, it just didn't go anywhere. And so I'm excited that we'll be rolling out more of this in 2020, so I can really be able to give a number to how many facilities are being truly recognized. On the far right is our consensus workshop, where we decided on the group decided on what essential elements were. And so, like I said, they can go through and they can pick things like injury prevention or community awareness, participation, anything that can help, increase their level in recognition. Some key points to think about is that I needed to engage hospital leadership right away to get that buy-in from the CMO, the nursing director, whomever, and have them complete that application. And then being able to do, even if it's just a small facilitated discussion with staff and leadership, doing a SWOT analysis, and then allowing them to do their self-determination. And then making sure that while they needed to work out some of their resources internally, that we provided them with some things like telehealth, injury prevention, and education. This is our copy of our certificate of recognition, and we do sign it and we do present it in a placard, and we try and do it in an environment where they have peers there. So we use our retrack process, which is has to do with our hospitals and EMS systems, and we have a very robust retrack system. So this is a great place for us to do those recognitions. The next thing that we was natural for us to try and recognize were our telehealth facilities, and those facilities who engaged in our community process and then entered into agreement to become a telehealth, what they call originating site. We are working with them to build a virtual pediatric ED. And so we decided that this would be a great opportunity to recognize those providers and hospitals as well. Next slide. The virtual pediatric ED, just for a quick overview, is creating a culture of being on shift together so that if they have a pediatric patient, they can use their ED equipment that we provide to them through the kindness of the HRSA grant, and that they can manage that patient together. So they are actually seeing the patient there, they're seeing the family. If the family does end up getting transferred to our institution, then we have a wonderful rapport with the family, and it really has worked out very well. We have two facilities that have the carts and that don't use them very often, but when we meet with them, they talk to us and they tell us about sometimes it's just nice knowing that you're there if we need you. We would like them to use this, but we're working on that. So we use simulation mannequins, and we do a lot of stuff with them. So this is another part of our telemedicine resources, is that they actually have access to our pediatric emergency nurses who can do nurse-to-nurse consultation. We can set it up so that you can have that as part of your staff meetings, and you're getting whatever you tell us what you want, or we can give you some, we have some packaged RSV, respiratory, IV education that we can do with you. And we continue to use our Child Ready Web Talk as additional resources for education. So that criteria is going to be that they participate in at least 3 telehealth consults per year, that they engage in 2 telehealth education sessions. And again, they can be 30 minutes, they can be an hour, whatever you need, and that they try and at least get it, either the resource inventory or the assessment. We can kind of see overall where their facility is at, but it's not required. And that they're working on something like even SIM education would meet the requirement to advance their level. This is just a map of the next slide is a map of our telehealth sites that we have across the state. So we have a fairly good, they cover most of our states, and we have some that work on Navajo Nation and with our IHS facilities, but the ones that are circled in red are our recognized telehealth sites. On the next slide, we're going to talk about our trauma. So while we have 37 hospitals in New Mexico, we only have 13 designated trauma centers, and the University of New Mexico is our only level 1. We have no level 2s. So in working with the Department of Health trauma manager, I really felt that it's important that if I couldn't mandate it specifically, maybe I could work with the system to include some pediatric specific criteria. And it was much easier to go in and just tweak the criteria than it was to try and change any kind of process to say, hey, your hospital has to do this. So over the last 2 years, we've actually been just trying out different things that we could include in the criteria, such as including PALS, including pediatric equipment. We took some of the stuff from the pediatric readiness assessment, and we kind of reviewed it, and we thought it pretty much dovetailed really well with our state guidelines anyway for designation. So if you meet that, those pediatric components that are listed in there, then your facility can be recognized as a trauma, pediatric child-ready trauma. And that does include that you add pediatric cases to your QI. So it's been well received. We make sure that they have injury prevention resources, and they can also use all of our transfer agreements and guidelines that we've made available to them from our online resources with EIIC. And that is a redesignation every 2 years. So we go out and I go out with the trauma manager, and I meet with the designation during the designation site visit, and we talk about the pediatric components. And that's when I'm presenting them with the materials for recognition. So the next slide is just kind of like gives you some areas highlighted in red where we've added pediatric wording, or some of these are some of the little tweaks that we made. The E means that it is essential that they have to have it. The D is desired, but most of the time they will make sure that they are working on those initiatives. So the child ready recognition is voluntary. You can still be a designated, but you may not be child ready recognized. The pediatric requirements are in the process of being reviewed under the rules. So while the designation isn't mandated, the requirements will be in the rules. We do have the state manager as our one of our advisory managers, and I told you ReTrack is really robust, and EMS for Children is engaged in the Trauma Process Improvement Committee, Medical Direction, and Trauma Systems. So that's how we're trying to integrate pediatrics into state measures. So EMS recognition was really actually pushed through with our initiative in the PEC Learning Collaborative, and we did this quick pediatric champions. We revised our fast facts. We created champions rather than the pediatric emergency care coordinator specifically in our state. It is a self-determination criteria for recognition, and the keys to this is that we've engaged EMS at all levels. We have the statewide advisory, we have grassroots with providers that participated in our process for the collaborative, and the EMS children position is a governor appointed to the statewide EMS committee, so we have access to those people at that level. Next slide is the criteria. I know I'm taking too long, I apologize. So we're looking at the pre-hospital providers, making sure that they have a pediatric emergency care coordinator or coordinators, that they participate in education events, which can be webinars, lecture series, and that they are coordinating SIM training or skills at their service level. Or one of the things that we've done with some of our EMS facilities is we've done a child ready web talk specifically around one of their cases that they've asked us to discuss, and then they get CEs for that. These are our levels. We do have the same thing, bronze, silver, and gold. And again, they can go in, this is an online system, and they can go in and actually do this online. And as they are inserting criteria, everybody starts out as a bronze, but the more things you choose that you're doing, then all of a sudden it'll pop up and you'll have a silver medal criteria. And then if you keep putting in more stuff, then all of a sudden it'll pop you up to the gold level. So that's kind of fun, and we are working on creating the same type of online system for our hospital recognition. And the next slide is just an example of what that looks like in our REDCap database. So we have, keep talking about this self-determination. So in our PEC collaborative, we created some core values. So improving pediatric care, becoming a champion, and advocating for pediatrics, while they don't necessarily fall with all those columns underneath them. These are things that they can choose to do as a leader. They can try and work with the care continuum. They can try and do things to improve things within their agency. So these are all things that they can choose to pick from. These are kind of open-ended kind of ideas, so we can work with them to redefine them as part of the process. These are more examples of some of the, in incorporating the skills training. I put that as part of our tech learning collaborative. We overlapped into that. These are ways that they can implement skills and equipment training to improve their scores in those areas. Finally, we are talking about disaster emergency preparedness. This was one that just came up recently in the last year and a half. So we are working with our Department of Health and our ASPR partners to address pediatric planning. And it is identifying some of those champions that are already in the communities, at the hospitals, and just having them start participating in the disaster drills, or start coming up with a disaster plan for their hospital if they don't already have one for pediatrics. And those are some of the criteria that we've come up with, and we're still hammering out what that's going to look like in the upcoming year. The overall goal is to make that entire community child ready. So they have pediatric champions. We do the facilitated discussion, and we try and organize at least one community event. Again, that's like the bike rodeo or CPR class, something where we can get in there and really give back. So over the years, we've accumulated CPR mannequins. I have a working relationship with our Medical Reserve Corps that they will go out and do those trainings for me. I just connect my resources with their needs. The next slide is kind of what we'd like this to look like. So at the end of the day, the ultimate recognition is that community participation and regionalization. And this is what it would look like. We would have a sign on every billboard going out of town or coming into town that would let you know that that community is child-ready. The very last few slides are just part of our resources that we've developed. We have a web page that links you to some of our educational material. I would like to mention at this time that our online education program is no longer available. We had some issues with the university and changing servers, and we are trying to overcome those by workarounds. So hopefully we'll have some online training again within the next year. But our website will eventually include a list of hospitals and EMS services and what their level is. And mostly in New Mexico, it's kind of a competition between our facilities, but it's also a way to see where your EMS service might be able to partner with a hospital to do like an equipment exchange or to work on the mass casualty drill that you want to do in the winter, you know, to prepare for winter. On the next slide is one of our resources that right now it's in a PDF, but it's kind of our background information. I'm going to put it onto a smart sheet. I have a student that's helping me do that. So this PDF contains our program information, some online tool information. There's QR codes to our Pediatric ED guidelines that anybody can look up and they have access to. I have online resources to internal, state, and nationwide. I have our EIC, I have different states that have made trainings available. And then one of the other things that, like I'm discussing, our state partnership with Kansas, they've allowed us, you know, not Kansas, I'm sorry, it's the EIC at the Interfacility Transfer Toolkit. So 2020 is our Child Ready 2020 initiative. We are starting off the year with a bang. Dr. Sapien and the Child Ready program was awarded with the Healthcare Leadership Council Redefining America Healthcare Award for his telehealth initiatives. In May, we will have EMS Day, which is being recognized by Governor Lujan Grisham's office in conjunction with her office recognizing that. They are going to be giving us recognition certificates for our pediatric champions who participated in the PEC Learning Collaborative and have been moving things forward in New Mexico with our EMS for Children program. So all of that, along with our hospital and EMS recognitions that we've been working on diligently in 2019, will come to fruition in July at our statewide conference. And that's it. Thank you very much for listening and for giving us the opportunity to grow.
That's fantastic, Karen. Thank you so much.
Sorry, Meredith, this is Kate Remick. Kathryn, I was just going to say you guys are doing really incredible work, and it's really exciting to hear about the disaster work in addition to the EMS work and the facility recognition. And I think this is a really nice demonstration of how each program has its own kind of personality, if you will, that best fits the state. I was just wondering if I could ask a couple quick questions. One is related to the PECs and how you've made that a requirement within EMS and hospitals. And I was wondering if you all had given any thought or, you know, ideas about the rapid turnover that we see among PECs with almost 50% turnover in a one-year basis. And if when you go on to these site visits, if you're talking to those organizations or facilities about the importance of really creating sustainability in that role, and or if you require any integration of that role into the overall organizational chart.
So we have talked about that because even when we were doing our updates for the survey that came out, we had so many contacts that we had to replace because they'd left the service or they just weren't doing that anymore. So when I'm having those discussions with the EMS services, I'm talking about an opportunity for these the techs who are currently in the position to start mentoring the new staff into the role of being pediatric champions. I said a lot of times, and I take this because my son is a new EMS provider through one of our county fire departments, and he has an opportunity to grow in so many different aspects. And I thought, well, what a great thing is that for these young people to be given an opportunity to see what Child Ready is all about, and then given some of their interest, actually create new pediatric champions with these new recruits. So I'm working with the leadership in our training institutes to really talk about, I'm giving them slides to talk about pediatric emergency care coordinators and to get that going in the paramedic training classes before they graduate. And hopefully it's something that they're, our Joe, and now I can't remember, it's our joint organization for educational EMS education. They are looking at trying to figure out where I can fit it into their curriculum so that pediatrics is being actually taught in the education institutes for our EMTs. So I'm trying to figure out new ways to get it out there, but I haven't figured out how to make the agencies make it a mandated position yet. Does that answer part of your question?
Yeah, absolutely. I love the idea of a mentorship program. It's really exciting, and I was mostly just curious. So thanks so much. Amazing work. It may have been a long road, but you guys have been immensely successful, and I think it's a nice model for how important dedication to the process is, even despite the ups and downs along the way.
And
Great job.
Have an honest interaction here. So when I was in Houston at the disaster conference and I was sitting with some of my colleagues from around the state listening to your presentation, which was amazing, some of the people behind me said, I don't know why New Mexico doesn't have something like this. And I felt so sad.
Oh, no.
I was like, we do. But it's just that it's so, I think that now is the time to push it forward with our national initiatives, because I think they're tired of hearing from us. I think you gave a fresh perspective. I loved that they recognized that. And I said, you know what? I was like, yes, Dr. Remick is masterful in her profession, and we are trying to emulate that in New Mexico. So we are working.
Well, thank you, Kathryn. I think you've more than gone above that. So well done.
Thank you, guys.
Kathryn, this is Diana. I have a quick question for you. I know part of the answer, but I haven't touched base with you in a while. I know that you have tribes in New Mexico, and I know that they have their own hospitals, and I know that you've made efforts to reach in and integrate Child Ready into their healthcare system as well. But I also know that there's 34 other states that also have tribes. Can you talk just briefly a little bit how you've been able to begin that work with the tribes, because that's a piece of facility recognition as well, and learning how to work with the tribes and integrate them into a recognition program is something that I'm going to bet that you and Arizona probably have done a better job with than a lot of the other states have thus far.
Now, we have been very fortunate to have Norman Coyate, who is our cultural liaison, working with us since 2012. And the approach that we've always taken with our tribal facilities is that we do engage tribal leadership first. We meet with them, we present our information, and we hopefully garner their interest and approval to pursue initiatives in their communities. With that being said, sometimes that process isn't actually as fruitful as we would hope it would be. So we meet with the healthcare facility, and 3 of our highest telehealth users are all in our IHS facilities, because that has actually been key to getting Child Ready in that tribal community. So the telehealth component has been instrumental in that. and the contract works in trying to create credentialing and proxy and is still ongoing, but at least we have some level. We've recognized Mescalero and Zuni for their telehealth initiatives. We are still we still work hard at getting into the leadership to do community work, but it is very difficult. So that's the best that we've done is we've engaged leadership. They know about us. They turn over. We engage them again. It's our process of just being that little gnat that doesn't leave.
You have been a gnat. You've done a great job, you and Dr. Sapien and your team. And I reiterate, it's been a long road for you guys, but you've done a great job putting together a very comprehensive program that looks at the needs of all of your communities, how they're different, and how you can best serve them. So thank you.
Thank you, Diana. You've been very helpful to us along the way as well. So we couldn't do any of this without you guys.
It's a team.
Yeah, it is.
Any other questions?
This is Kate Remick again, and I just have one more question, maybe for both Karen as well as Kathryn, if Karen's still on, which is how you all go about doing any kind of training for site visits, or if you do that. So how you train the physicians, nurses, and others that might be joining you on these site visits.
This is Karen. We currently don't do a lot of training. We do have we did come up with a list of criteria that they have to meet in order to be a site review member, and they have to send it into my office, and then our working group reviews it before we give the okay that they can be on the site review team. But most of especially at the basic level, which we're currently at now, it's pretty self-explanatory for anybody who would meet the requirements to be a site review, if that makes sense.
Okay, perfect. Thank you.
And in New Mexico, the trauma system identifies the people who are going to be doing their designation, and then I am the child-ready person for that site visit. And then Dr. Sapien always looks at anything that comes out. Our community visits that we do, Norman leads us in our facilitated discussion. So that's the process for those other visits.
Thank you, both. Helpful.
So one last question we had for everyone on the call. We see about maybe 22 didn't answer to the poll. And maybe we wanted to ask maybe why you didn't answer. Was it that I didn't put a 0 as an option, or you're not a state partnership manager, or maybe you don't know, or prefer not to answer? If you guys want to use the chat box, we would love to know maybe why we didn't get a great response. That would be fantastic. In the meantime, wanted to remind everyone that our next call is going to be at the end of April, the 29th at 1 o'clock Eastern, 12 Central. And we wanted to know any suggestions for topics. What would you like to hear? Where are your struggles? How can we better support you? And you can use the chat box for that as well. Any other comments, questions?
So just by way of kind of trying to bring up ideas or thoughts, we really want to make sure that we know who all is on the call in terms of the various phases, because as we think about preparing for future calls relative to this community of practice, we want to make sure we're meeting the majority of where you are. And that's why we kind of went through some of those phases before. And I know it's really difficult to remember what all of those different levels were. So if for any reason you didn't answer the poll and you would like to just kind of submit a level privately to the host or presenter, we would love to be able to add that in. So if I can just quickly go through each of those levels, and you can feel free to enter a chat to
it should be listed as Cassidy Penn as the host, even though it's really Meredith Rodriguez, but we'd love to at least know what your level is. So level 0 is you're just beginning on this adventure and you're not really sure, you know, what to do. Level 1 is that you are beginning to pull together a champion team. You've decided that this is a priority, and you're really trying to figure out who should be part of that team from the advisory members. Level 2 or stage 2 is that you're beginning to really research a little bit more about your state and trying to figure out what levels or what is the overall framework within your state and how to go about moving through that to begin to look at recognition. Stage 3 is really beginning to think about developing an implementation process or plan, but really trying to get stakeholder agreement and support for that. Level 4 is to begin to develop that implementation or piloting process. And level 5 is actually having one facility formally recognized or more. So if you'd be willing to share where you think you fall into that, it would be most helpful as we prepare for future calls. So, okay, thanks so much for those of you who are responding. And again, if you don't feel comfortable sharing publicly, please feel free to share just directly with Cassidy, and that's perfectly fine. There is no shaming in communities of practice. We're just trying to figure out what your all's needs are and be as honest and realistic about that so we can help provide additional support for you as you move forward. And then again, if you have any real specific needs, suggestions, recommendations of what would be most helpful around these different stages, if it's, you know, you really need to better understand the varied state frameworks, or if you want to better understand who should be part of your core team and why, if you really want to understand, you know, ways of developing criteria and bringing stakeholders together, how to look at the implementation process in more detail or develop an application process. Those are things that we can try to focus on for future calls. So feel free to shoot us a text through the chat box around that as well, and or give us an email about what would be most useful for you as you embark on this process. So we'll keep the line open for just a few more minutes for those who want to continue chatting, but special thanks to Kathryn and Karen for sharing such great work today. I know everybody really learned so much from all of you, and we're most successful when we can learn from each other and share those successes and best practices. So many thanks for your willingness to do that, and maybe one of the other folks on the call, we might be reaching out to you in future communities of practice, because this really is about I'll teach, I'll learn. Thanks again to Meredith for organizing this call and bringing everyone together, and for your all's ongoing participation.
Thank you, Kate. Thank you, everyone. Like Kate said, I'll leave it running open for a little bit longer. You all are welcome to put your input in, and both thanks again to Karen and Kathryn for some great presentations. So, thank you all.
Thank you, guys. Appreciated the opportunity.
Thank you.